I'm Kate Stolp, former chair of physical medicine and rehabilitation at the Mayo Clinic and currently president-elect of the Association of Academic Physiatrists. And I have the honor of being here tonight with Dr. Murray Branstetter, who is currently professor and chairman of the Department of Physical Medicine and Rehabilitation at Loma Linda University in Loma Linda, California. Dr. Branstetter has been president of most of our national professional organizations and has been a delegate to the American Medical Association and has numerous experiences in leadership. And it's quite an honor to be here with you tonight, Murray, at the meeting of the American Academy of Physical Medicine and Rehabilitation tonight. And just have a few questions for you based on your experiences in the field over the past years. So to start with, I wanted to just ask you, with what you see in PM&R, what do you think the top 2 or 3 issues are that face our specialty, especially in the upcoming years?
Kate, it's a pleasure for me to be here. Not an easy question, but let me answer it quickly and simply. I, along with my other 8,000 colleagues in physical medicine rehabilitation, really believe in what we do. We believe we help people, and we do. But much of what we do actually has not been proven to be successful scientifically. So I think that one of the really important things facing our field is for us to support the research initiative to establish scientifically and proof that what we do actually works. We all believe that, but I think those who are paying the hospital bills and insurers really need to know that what we do is actually what we claim to do. Secondly, I think that the field is rapidly changing. Our patients are becoming sicker. More and more patients are surviving in the ICU, and we are admitting more complex patients onto our inpatient rehabilitation unit. Cancer rehab, for example, organ transplant. Many of the patients admitted to our rehab units are therefore more challenging for us, and we have to adapt with the time. So adjusting to the changes in the specialty are very important. For in the outpatient setting, adoption of new technologies and new interventions. So a second a crucial item, I think, is simply adapting both inpatient rehabilitation and outpatient musculoskeletal care, adapting to the new technologies and new challenges facing us. Thirdly, I would say in the face of the pressures for cost control and the likelihood that there will be downward pressure on our ability to admit all of our patients, to make sure they have access to rehabilitation, we have to advocate for our patients to make sure that those who need our services actually are able to benefit from them.
Thank you. Those are all very provocative issues, and I agree, very challenging. So with your years of experience in leadership in our field, how do you feel that has helped you better understand the issues facing our field?
Being in a leadership position, I look at it 2 ways. You certainly have to take care of the detailed, day-to-day business of providing patient care, running a department, and so on. But being a leader, I think, puts you in a position of taking a bigger view, a bigger picture of what needs to be done, identifying the future strategic needs of the field, whatever it is, but in physical medicine and rehab, to appreciate what the new trends are in the field and being able to incorporate within your strategic planning and working with your colleagues to try and make that happen. I would say really establishing a big view of the whole specialty rather than simply being stuck in the day-to-day things that you're doing every day, treating patients and so on, but being able to step back and set some priorities based on what is really happening in the bigger picture.
So currently, what initiatives are you working on that are new in either research, education, or practice?
Well, in research, I'm personally involved primarily with inpatient rehabilitation, neurorehabilitation in particular. And I've been fortunate to participate as a multi-center trial for stroke rehabilitation, and currently just finishing a project with inpatient brain injury rehabilitation, attempting to discern really what are the factors that that influence patient outcomes for the better, the best things that contribute to good outcomes, and I found that challenging, but also very rewarding, because I think we are getting at the issues of importance that we can identify as being responsible for good patient outcomes. Education, with regard to residency education in particular, we have to keep abreast of the developments in the field and medicine generally, and to make sure our residents are fully prepared to enter practice. The practice that they are entering now and will be entering in the next year or so, very different from what it was even 10 years ago. And we have to be willing to change our approaches and the content of training to make sure they are able to capture some of that importance in their preparation for work, so that they can continue to commit to this being a lifelong learning experience. I'm still learning. I want my residents to feel that they don't just practice what I've taught them, but they will continue to learn, even if what I've taught them now in 5 years is out of date. They will be able to keep up to date.
Thank you. I have one final question.
Yes.
What advice would you give to aspiring leaders in our field?
I would say for residents graduating from programs, my advice is commit yourself to being the best that you possibly can be, putting patients first and foremost, and committing your professional life to one of continuing self-learning and self-education, so that you will be able to not only practice good medicine now, but will be able to continue to practice good medicine in the future.
Thank you so much. It's been so great to be able to speak with you tonight. It's wonderful to have you here at the meeting. Thank you.
It's my real pleasure. Thank you.